So good afternoon, everyone. Welcome to this 96th session of e-NISCHIT, the National Initiative to Strengthen Collaboration between HIV and TB through e-learning. And before we begin today, I would like to introduce my team. On my left, I have Dr. Jyoti Sharma. She is the logistics manager and the coordinator for this clinic from Share India side. Then we have Mr. Rakesh, who's the IT coordinator, and we have Mr. Nitin, who is from Share India, from Echo India. So this is actually a collaboration of so many people, it takes so many people to work at the back end. And after that, I would like to introduce and welcome our medical specialist, Dr. Ashwani Khanna. Dr. Ashwani Khanna is a very senior chest physician, and we have actually been interacting with him for several years now, and we have learned a lot from him. He is also a consultant on the National TB Elimination Program, and he was also our state TB officer for the Delhi state for several years. Welcome, sir. Thank you so much for taking on this complicated case.
Thank you, Dr. Upasna.
And now I'd like to welcome all our ART centers, the entire teams, the SMOs, the MOs, the staff nurses, the counselors, lab technician, care coordinators, whoever is there from all the 13 states of Delhi, Uttar Pradesh, Andhra Pradesh, Tamil Nadu, Assam, Arunachal Pradesh, Manipur, Meghalaya, Mizoram, Nagaland, Tripura, Sikkim, and West Bengal. The case that we have today for presentation is actually a case which had multiple episodes of TB, and eventually it got converted to a DRTB. And the case presenter is Dr. G.Brundha from Tamil Nadu, Dharmapuri ART Center. So can I please now request our case presenter, Dr. G.Brundha Govindan, to please make the case presentation?
Yes, ma'am.
Thank you for sending in this case.
Okay. Good noon to everyone. I'm Dr. Brunda, ART Medical Officer from Dharmapuri ART Medical College, Tamil Nadu. Now today I'm going to present this case because patient having repeated infection by the Mycobacterium involvement of right cervical lymph node for the past 10 years. Even though she has a good CD4 count and the viral load copies are less than 1000. But again and again that patient get the reinfection. So that's why this case motivated to me to present this case today. Actually, this case was identified as HIV reactive during 2005 at Tambaram, Chennai. That time that our CD4 count was 416. She has been maintained as pre-RT patient until 2011. After 6 years of pre-RT continuation, patient developed fever, cough. So that patient sent for sputum AB. That time CB-net was not available, so we sent them for sputum AB. That gives sputum 2+ positive. And CT abdomen was taken. Now we don't have that image in my hand. So just I wrote it down. TB abdomen shows multiple para-aortic, perihepatic, and bilateral common iliac node involvement. That time her CD4 count was 262, weight 43 kg. So we started category 1 ATT. After completion of ATT, patient was started on ERT under regimen stavudine, lamivudine, and efavirenz based regimen. After 2 months of ATT completion, again the patient having the complaints of right cervical node enlargement with FNAC report diagnosed as cock lymph node adenitis with sputum pus AB shows positive for AFB on March 2011. Then the 2012. So we considered as TB relapse. Then category 2 was started. After completion of ATT category 2, then again the patient having the similar complaints of that means the enlargement of right cervical lymph node. Patient went private clinic. At the time we don't have any investigation at the private sector. So at the time that the patient was started on category 2 by the private hospital. There he took ATT for 16 months. After that, the patient again having the similar complaints of right cervical node lymphadenitis. That time, the patient first was sent for gene expert. It was diagnosed as rifampicin resistant DRTB. So at GSTM Tambram, Chennai, the patient was started under DRTB. After 2 years of completion, again the patient having the similar complaints of cervical node enlargement. So this time, what they did means they sent the first for extended drug susceptibility test. That test shows culture negative resistant for rifampicin and sensitivity to all the drugs. But gene expert gives MDTB detector rifa resistant. So again that patient was started for category 4 MGR-TB drugs and she completed 2.5 years of drug. Then after, again the patient having the similar complaint, extra pulmonary TB at right cervical lymphadenitis. FNAS is sent here at our medical college. This time shows that Cox lesion at the site of a right cervical node. Sputum, there is no sputum production, so we didn't send for CBNet. Then we finally started with category 1 by our TB pulmonologist opinion. After 6 months of completion, patient cervical node was regressed. So follow up FNAC not able to done this patient. After all category 1, 2 times of category 2 ATT, then she was taken 2 times category 4. Then 1 year before also she was took category 1 ATT. But why this patient having repeatedly involving the right cervical node? That is my question, sir.
Thank you very much, Dr. Brunda. That is actually a very good case presentation. And it has, the data has been collected over several years. A decade of data is there. So we can understand wherever there are little missing data, that is understandable. I have just one question to ask you. In the TB that took place of the cervical lymph node in 2012 and then in 2012, you have no data because it was all done in private sector. But she continued ART from Tambram, is that right? One query that emerges here is that I hope she continued her ART when she had gone for TB treatment to the private sector. The second query that emerges is that the TB in 2014 was a cervical lymph node TB, and then again in October 2016 was a cervical lymph node TB. So the samples for which they are showing the tests, are they a needle aspirate or are they a sputum samples? That is another thing that we need clarity on. Can you connect to Dr.
Yeah, the samples are aspirates. Okay, so they have done a gene expert from the sample which has been aspirated from the lymph nodes.
Okay, sir.
So no pulmonary. It's all extra.
It's all extra pulmonary.
Same site, same node.
Okay, sir. Same site, same node, and culture negative, but expert positive has come the next time. Yes, sir. तो अब मैं केस को समराइज करूंगी. इस बार हमारे हिंदी स्पीकिंग और इंग्लिश स्पीकिंग दोनों स्टेट्स हैं. So to summarize the case before we move on to the didactic by our expert doctor, I would like to tell you कि एक PLHIV थे जो कि 2005 में रजिस्टर हुए थे इनके सेंटर में तमिलनाडु में. रजिस्ट्रेशन के वक्त इनका CD4 416 था. 416 416 CD4 at the time of registration in 2005. The patient at the guidelines at that time did not need the patient to start on ART, so he was kept in pre-ART follow-up. उस वक्त की गाइडलाइंस ऐसी नहीं थी कि भाई इसको ART दिया जाए 416 पे, तो इनको प्री ART में रखा गया 2011 तक. अब इनका साथ क्या हुआ कि 2010 में इनको पल्मोनरी टीबी और पेट की टीबी हो गई. In 2010 this patient developed pulmonary TB and abdominal TB. Pulmonary TB में तो इनके sputum AFB positive था. उस वक्त there was no CB-NAT at that time. हाँ, तब CB-NAT नहीं होता था. और इनका जो CT scan था पेट का, that was showing multiple abdominal lymph nodes. इस बीमारी के लिए, इस वाली टीबी के लिए, जो कि दोनों फेफड़ों में भी थी, पल्मोनरी भी थी और एक्स्ट्रा पल्मोनरी भी थी, इन्होंने 9 महीने की कैटेगरी 1 ली प्रोग्राम के अंदर. ये इन्होंने जैसे ही कंप्लीट किया ट्रीटमेंट, इनका ART भी स्टार्ट कर दिया गया. और उस वक्त SLE होता था, स्टैवुडीन, लैमिवुडीन, इफाब्रिल्स, उससे इनको ART स्टार्ट करी गई. पर 2 months लेटर, 2 ही महीने बाद उनको राइट सर्वाइकल लिम्फ नोड डेवलप हो गया. और 2011 में जब इसकी जांच हुई तो फिर से देखा कि इनका बलगम जो है वो स्पूटम पॉजिटिव है और राइट सर्वाइकल लिम्फ नोड भी है. तो इनको अब कैटेगरी 2 ATT दी गई और ART कंटिन्यू किया गया 2011 में. जब इनका ये वाला एपिसोड ऑफ टीबी के ट्रीटमेंट खत्म हुआ तो 2012 में इनको फिर से सर्वाइकल लिम्फ नोड था, वही उसी जगह पे फिर से सर्वाइकल लिम्फ नोड दिखा. तो ये प्राइवेट में चले गए पेशेंट और इन प्राइवेट इन्होंने ATT ली 16 महीने के लिए और ART इनकी ART सेंटर से चलती रही. उसके बाद क्या हुआ, 2014 में ये लिम्फ नोड तब भी था और अब की बार जब लिम्फ नोड से इन्होंने एस्पिरेट निकाला, FNAC करी और उसको जीन एक्सपर्ट लगाया. अब तक जीन एक्सपर्ट आ चुका था तो उसमें रिफ रेजिस्टेंस निकला. जब रिफैम्पिसिन का रेजिस्टेंस निकला तो ये अब ड्रग रेजिस्टेंट टीबी हो गया और इनको ड्रग रेजिस्टेंट टीबी के लिए 2014 में कैटेगरी 4 देते थे. इनको कैटेगरी 4 ट्रीटमेंट मिला और ART इनकी चलती रही. जून 2016 में इनको कैटेगरी 2014 से लेकर 2016 जून में इनकी कैटेगरी 4 खत्म हुई. फिर उसके बाद 2016 में फिर से वही लिम्फ नोड था तो इनको एक बार फिर से कैटेगरी 4 दे दी गई. लेकिन इसमें इंटरेस्टिंग बात जानने की ये है कि इनका जीन एक्सपर्ट तो पॉजिटिव था, जीन एक्सपर्ट में रिफ रेजिस्टेंस भी आया था. वही लिम्फ नोड है जिसके लिए ऑलरेडी ये दवाई खा चुके हैं 1.5-2 साल. तो उसमें तो जीन एक्सपर्ट पॉजिटिव आ गया, वो है भी वही पुराना टीबी का कीटाणु है, उसमें रिफ रेजिस्टेंस भी है. पर इनका कल्चर जो लगाया गया FNA का, the fine needle aspirate was put for culture which came out to be culture negative. However, the patient was given CAP4. Now, once again in September 2021, this is nearly 4 years after the 2016 episode, 4 to 5 years later, he has again the same cervical lymph node for which the pulmonologist advised him to get category 1 treatment. And this time there was neither sputum nor an aspirate was tested by gene expert. However, ART has been taken very diligently by the patient. The target has always been either non-detectable or below the limit to say that the patient has developed a resistance to HIV, first-line HIV drugs. Adherence is very good. Otherwise, health status is good. So the question today that Dr. Brundha is asking is that when he is taking ART, this patient is taking ART properly, then there is a good rise in CD4 count, viral load is well suppressed, then why is the patient getting TB again and again? Now, this is a very relevant question. And one question that can arise from this is, are all these episodes actually relapses or reinfections of TB? Did all these episodes require treatment, or were they just leftovers of the previous episode, some stagnant TB or stagnant TB bacilli in the lymph node? So why was it that all of them were treated? Should they have been treated? Should something more have been done than the regular CAT1, CAT2, and CAT4? So for all these things, we would like to invite our expert, Dr. Ashwani Khanna, consultant to the National TB Elimination Program, for his didactic. And
thank you, Dr. Upasna, and thanks the e-NISCHIT team for giving me this opportunity to be here and share my thoughts on the case with you. So, like you already said, it's an interesting case, and based on whatever the information which has been provided, even though it's sketchy, we have come to some conclusion on the possibilities. So I'll talk about them here, and then in the didactic, we'll cover up everything which needs to be covered in relation to this, presentation. So in the first episode, which has been presented, which has been shown to us, we found that the 35-year-old female was started on anti-tubercular therapy of sputum positive TB and abnormal TB in 2010 with category 1 regimen. So this patient was sputum positive, new sputum positive, never taken treatment earlier, and that was the standard of care at that time. We had no other diagnostic facilities what are available now. So the patient was started as per the guidelines, but the second and third month sputum was positive and there was no decrease in positivity. This I've just picked up from all the information which has been given to me. So that means there was no conversion. But a 5th month sputum was negative. That report is available. But this end of treatment, the sputum sample was not done because I've not found what has happened to end of treatment in this patient who was basically a pulmonary TB case. So we are not very sure whether the patient was still positive or was still had become negative. But the treatment was taken up to 9 months, possibly because of extrapulmonary involvement. So duration was fine. There is no clinical guidance to response to therapy. I don't know how the weight gain was there, the clinical fractures, there are no radiology available. And we don't know whether the patient's sputum was reverted. So what I mean is you have 2 sputum positive at 2nd and 3rd month, no decrease in positivity. So in view of all this and non-availability of the last sample, we are, without decrease in positivity and no end of sputum, we are not very sure there was a successful outcome of this patient. It could be possible the patient was still positive. And this is more, feasible because when we see to the next episode, it just starts after 2 months and the patient is positive. Can you move to the next slide? So in the second episode, the patient was again positive. It just started 2 months after finishing the 9 months of therapy. And along with that, sputum positive lymph node was available, as an extrapulmonary site. The patient took treatment. Initial sputum were negative, but a 6 month sputum was still positive. It's 5th or 6th month, which showed a scanty sample. Because the patient who was taken treatment with a category 2 regimen, which has 5 drugs including streptomycin, we expect it to become negative, provided the patient has taken the therapy regularly. Or it could be possible the patient was resistant to other drugs and streptomycin being the lone drug being given initially the response and later became positive. The patient was started in March 2011 with category 2, but what we found was sputum samples after 6 months were negative, but the patient continued taking ATT for 16 months. Sputum positive patient in category 2 normally completes the treatment in 8 to 9 months in those days. And they were waiting the culture, which was awaited. But why was the patient taking treatment for 16 months? It's difficult to understand. The only I can see reason is the patient was not responding. Even the sputum, there's report what is said is sputum was negative after that. So there is no response of therapy. And again, we move to the next slide. Soon after, another 1 or 2 months later, the patient now move to the next one. Move to the next one. In the third episode, patient goes to a private setup. This is again after 2 to 3 months of, generally after this, that means patient is not responding. Otherwise, why should a patient go for a lymph node which was present and persistent enlargement? It took treatment for, I think, 5 months, not 3 months. And the patient took as per the guidelines. But from the private sector, we are not sure, we have no record. So we can delete this episode because it is not under the purview of the program and not what happened. Move to the next episode. Now, this is the episode which is most important what we talk about. The persisting and enlarging lymph node was the first time subjected to CBNAT. That's when the patient goes and a CBNAT done in April 2014, and it was found to be resistant. Now, this is the episode where it shows that the patient is not responding earlier and the resistance has been, been detected. Now, why the patient has, developed resistance or whatever the reasons, we'll discuss in the didactic where we'll bring about this topic. What was the cause? Could be the cause. So the category 4 regimen was started, which was a standard of care at that time, with 6 drugs, including injectable kanamycin, fluoroquinolone, ethionamide, cycloserine, paracetamol, and ethambutol. And this was a standard treatment which was given for a period of 2 years. And we saw that the patient responded to treatment because the lymph nodes regressed inside. And this was more important because they tried to take a sample out, aspirate, but the aspirate, they couldn't get anything. So no culture or DST could be done. But this is an episode where a treatment as per the national guidelines was given and the patient has responded after ending 2 years of treatment. Come to the next one. So my question is, were we dealing with MDR from the very beginning? Because the patient was positive, continued staying positive, and whatever reports, even end of treatment in the first episode was not available. In the second episode, when the patient took treatment for 16 months, it is possible the patient is not responding. That's why the treatment continued for 16 months. And now, after 4 months of when we started the category 4, the patient has responded. That means it is possible. We are dealing with a drug-resistant TB from the very beginning. It was a primary, and we'll talk about what are the different types of drug resistances later. So it could be a drug resistance which has developed with irregular therapy. We are not very sure, or adherence was an issue, or it could be a bacilli was resistance from the very inception. So this could be what a reason for non-response to therapy. Can we move to the next slide? Now, in 2016, soon after, again, as soon as the patient, there was a lymph node, and the patient had just finished category 4, and again, they did an aspirate from the lymph node. Maybe the size is not mentioned. We are not very sure how big it was, and it was the same, or there were multiple lymph node or a single lymph node, but we presume it was a single node which was persistently showing up, and the culture of aspirate was done. Gene expert showed they were dealing again with a rifampicin resistant bacilli. Now the culture is negative. Why should a culture be negative in a patient who has been treated and not responding? Are we dealing with a dead bacilli? Because molecular tests will show the presence of bacilli, but culture is required to be shown as bacilli which has grown to show that the bacilli are living and they're not dead bacilli. And the patient is treated in XDR now. XDR means a treatment in that time was for 30 months, and patient took 30 months of treatment based on the gene expert report and a culture negative report. So there is whether we needed to treat this patient now or not, it is an issue. Next. The 6th episode is very difficult to explain because no aspirate was done, aspirated. Histopathology just showed necrosis. We have no idea what was the CBNAT report, what was the culture report. And this time patient was started on drug sensitive treatment and the lymph node decrease. Again, issue, why was this treatment given? Can we move to the next slide? So in short, I have discussed the different episodes. So to just summarize what it could be, in view of the presentation and response to therapy, we could be dealing with a primary drug resistance. That means a patient's bacilli were already resistant and they were being given treatment for drug sensitive TB, because at that time, the treatment of drug resistant TB or detection of TB was not available. Not the treatment, but for detection. Or it could be acquired drug resistance, because it could be possible the patient has not taken drugs properly, could be adherence issues, could be inadequate regimens. We will discuss them later. What could be the reason of acquired drug resistance? So this has led to multiple episode treatment till the MDR was finally diagnosed and treated. This was the first time it was found that bacilli they were dealing with were MDR, and the patient responded. The further episodes, that is the 5th episode where XDR treatment was given, could be dead bacilli, as no growth by culture has been demonstrated after the first treatment of drug-resistant TB. Now, what do we do? How do we manage this case? In this case, it could be that we are dealing with the lymph node which is persisting, which is showing up because whatever any other reason, and lack of radiological and clinical details, affects the picture. But here, in a patient who's having repeated episodes, has been treated well for DRTB, culture has been negative, a lymph node is showing, the best option will be to surgically remove this lymph node and hope that this was the cause. It's basically a dead bacilli you're dealing with. The disease has been cured, and treat him in a surgical manner. So this is what I like to end up as the case summary before I move to the didactic part and discuss a little bit of details on it. So I think we can open up, Dr. Upasna, any questions based on what we have done, what I've talked just now?
Yes, sir. I'll just ask Dr. I think Dr. Brunda, is it clear what sir has discussed till now? I think it was quite clear the way he has told us, but still, if you have any questions, please feel free to ask, because it's very important that your doubts are cleared now.
Okay, ma'am.
Any question?
Ma'am, 10 days before the patient again came with the enlargement of lymph node without any fever, cough, or weight loss. Then we send them for again FNAC. The futures that report came as this is suggestive of reactive lymphadenitis, ma'am. And
Okay.
then after normal antibiotic treatment, that size was regressed.
So this gives a more picture what we are talking about. We are dealing with a non-infective case, could be a reactive lymphadenitis which has been treated as an active disease, because necrosis and all the features you see in histopathology are there, but they might persist. And similarly, a dead bacilli might persist.
Okay.
Yes, Dr. Upasna.
Yes, sir. I think, Brenda, is that clear that probably the treatment after the category 4 treatment, after that initial category 4 treatment, following that the next episode in which the culture was negative, only CBNAT was positive. And as Dr. Ashwani has told all of us, that the histological picture and molecular tests, all these can continue to remain positive from previous episodes.
Okay.
That doesn't mean that the patient has got a new episode. This is actually trapped bacilli inside the body of the lymph node, which even though the TB has finished from the body, they have not been able to be expelled.
Okay, ma'am.
So probably after that first episode of CAT4, which was very appropriately and correctly given, further episodes were further treatment is probably not required, and all that is required if the lymph node is physically troubling the person is to get it surgically removed and done away with.
Okay, ma'am.
And it would be a good idea to send the excise sample also for a culture.
Okay.
And can I just for MTB culture, just to be double sure. It's never a bad idea to be double sure. And can I please ask anybody else if they have any question? And as Dr. Ashwani said, most likely it was MDR-TB right from the beginning. Because right in the beginning, when we were giving category 1, category 2, the patient was having positive sputum, then there was a lost track of what the sputum was there at the end of treatment. We could not trace that, or we don't have a track of that after a decade. And then again, the patient was not doing well. He was going on getting treatment, sometimes in the private, sometimes in the public sector. So most likely this patient had either a primary MDR or an acquired MDR right from the beginning. But because of lack of modalities of testing under the national program during that time, we could not pick up MDR-TB at that time, and we gave whatever treatment was recommended under the program at that time. Is that also clear, Dr. Brundha?
Yes, ma'am.
So anything else you want to know about the case before we go on to the didactic?
No, ma'am, thank you.
During this didactic, I will just talk about what is drug resistance, what is the type of drug resistance, how common is the drug resistance, how common is it in India, what are the various surveys, everything in short, how we treated TB earlier, what were the results of TB, outcome of the treatment of drug resistance, and finally, a word about what we are treating them now, what is the standard of care of present, because whatever this happened has happened at the time when the treatments were different. Now we have a different treatment. We'll talk about that, and a short word about what we are looking at future in very soon. What will we be looking at the treatment of drug-resistant TB? So when we talk about drug resistance, the bacilli are there. They can be resistant to one or more drugs, anti-TB. So that's drug resistance. But naturally, what happens is if the number of bacilli are large, that is 1 raised to 10 raised to the power 6, that means over 10 million, you can have a natural resistance to INH. So there's a bacilli which is naturally resistant, but for that, the number has to be very high. And for rifampicin, it is 10 raised to power 8. So for MDR, it is 10 raised to power 14. That is resistance to both INH resistance. So for a single bacilli to be naturally resistant, you have to have a large number of bacilli present. And this is normally seen in large cavities where the number of bacilli are very high and very unlikely in a extrapulmonary site, which are paucibacilli. So what are the causes of drug resistance? Can be poor treatment increases the risk of developing of drug resistance. One is the natural resistance. And why does it go up? Because if you give a drug treatment with single therapy, very often it happens when the patient feels that this drug is causing problem, you use single drug. It can cause drug resistance, irregular consumption. Sometimes you take the drug, sometimes you do not take, or you take irregularly, or you take repeated interruptions. They could be because of the patient is not tolerating the drugs, because of ADRs, or a trial therapy. Very often we do a trial, let's see, use this drug and see whether the patient responds. So these are the few causes where the chance of drug resistance developing goes high. Next. So what are the types of drug resistance? When we talk about drug resistance, let's talk about what is drug susceptible TB. Now that is the TB where the specimen is sensitive to both rifampicin and i-NITH, or let's put it, it's not resistant to rifampicin and i-NITH. That means it's sensitive to these two important drugs. This is drug sensitive TB. That's the way we used to use, what we use a drug sensitive TB regimen, which is a 6-month therapy with 2 months of 4 drugs, that is rifampicin, i-NITH, ethambutol, and pyrazimide, followed by 4 months of 3 drugs, that is rifampicin, i-NITH, ethambutol. Most of the patients fit into this criteria, and most of the people will be getting this regimen. And this is a 6-month regimen. If properly taken, will bring about a cure in over 90% of patients. Now, what we talk about drug resistance is can be monoresistance, it can be polyresistance. Monoresistance is any of the first line your resistance is called a monoresistance. It can be any drug. If it is resistant to i-NITH, it is called i-NITH resistance. But here the patient is resistant to i-NITH, but is sensitive to rifampicin. So it is just a single drug resistance. Then we have polydrug resistance. That means patient is resistant to more than one drug, or more than one drug, 2 drugs, 3 drugs, 4 drugs. But these drugs should not include i-NITH or rifampicin. If a patient is resistant to both i-NITH and i-NITH and rifampicin, it is called MDR. We'll talk about that later. And then there is a single drug resistance, rifampicin resistance. A TB patient whose biological specimen is resistant to rifampicin, detected using a phenotypic or genotypic method without resistance to or with resistance to other drugs. That means a patient is having rifampicin resistance. If he is resistant to, with a pyrazimide, it's called rifampicin resistance. But if he is resistant to rifampicin and i-NITH, these 2 drugs together, because they are 2 most important drugs, it is called MDR. A patient who is resistant just to i-NITH and sensitive to rifampicin is called i-NITH resistance. These 3 I'm talking about, these are the 2 important drugs. If there is a resistance detected to them, they have to be treated accordingly. So patient with i-NITH resistance has a regimen which is separate from drug sensitive. And a patient for rifampicin and other resistance, the drug regimens are different. Next. So what are the causes? Causes can be microbial, it's because of microbe. It could be clinical, it could be the programmatic causes. I am talking this because the patient has to be treated properly to prevent emergence of drug resistance. The cause of the bacteria is by genetic mutation, what I've talked about, and that makes a drug ineffective against the mutant bacilli. So if there is a mutant bacilli, we have to give multiple drugs so that the organism which is resistant to rifampicin is killed by other drugs. But the number is so low. Then clinical cause can be inadequate or poorly administrative treatment regimen. Next. So in the program, we have a well-running program. We have to make sure that the patient is given drugs as per the guidelines. So if there's a program is inadequate, or the providers are not well trained, there are no guidelines which are there in our country. But if you don't comply with the guidelines, or the inadequate training of health staff who are not monitoring the treatment, or in these cases, there can be a development of drug resistance. Similarly, it can be drug related. There can be times when there are stockouts. We have stockouts in the country sometime, but they have to be taken care of at the local level, or the quality of the drugs are poor, or they're very poorly stored, and wrong dosage or combination given. That could be because of drugs, and this can also lead to drug resistance. And then because the patient, he's not adhering to the treatment, he has no information, there are non-availability of free drugs, at times he has to buy, he might not buy. Then there are drug reactions. Sometimes patients have drug reactions, they do not take the drugs, and if they do not take one of the drugs or 2 drugs for a long time, we can develop resistance. And malabsorption, important cause but rare cause, because the patient is not absorbing the drugs, the levels are not being reached properly. So since the levels are not reached properly, they are not able to kill the bacilli. Then substance abuse, a lot of these people can be drug addicts, can be tobacco abusers, and they are not adhering to the therapy. So these are some of the causes which are important that you look into it and make sure that the patient you put on treatment does not develop drug resistance if the patient is drug sensitive. So how do we diagnose the patient? You have a diagnosis, or diagnosing tool is to have to show that bacilli is there. You have smear microscopy, you have nucleic acid amplification test. We are having TrueNAT and CBNAT now, and then the culture. These will tell you that the bacilli are present. But supportive tests do not show about the bacilli. They just help us and support us that if this is positive or X-ray show shadow or TST is positive, it could be TB. It is not diagnostic. But we must know whether the patient who we are dealing with is having a bacilli which is sensitive or not. We should make sure that the treatment is given based on sensitivity testing, and that is the standard of care now. When we started on this patient, we found that this patient was not tested because these tests were not available. Now we have a molecular test. These are NAT, which I talked about, CBNAT and GeneXpert. And for all patients who are HIV positive are getting upfront NAT. And NAT will give you results in 2 hours. This will tell you about rifampicin resistance. Then we have line probe assay, which is a molecular test normally done on a positive sample, and it gives a report in 3 days. We have a first line LPA and a second line LPA. The first line LPA will tell us what resistance to rifampicin and INH, and second line LPA will tell about with fluoroquinolones and injectables. So these test results are available very rapidly within 3 to 5 days, NAT the same day. So there's no delay in diagnosis. Culture is another test. We have solid culture. Sometimes we do not have bacilli in such large number for detection, where we cannot do line probe assays. We have to subject them to culture. Moreover, to make sure we are dealing with live bacilli, how we are following up a patient, it is culture. Because sputum might continue being positive, but the bacilli are dead. We know we are having a dead bacilli, not a live bacilli. So culture with a solid medium, which we used to do earlier with LJ medium, it takes about 12 weeks. And liquid culture, which is rapid or MJIT system, which is in place now all over, will give us results in 6 weeks. So we have these diagnostics by microbiological tests and culture methods, and we have the availability of tests which tell us the susceptibility of the organism at the very beginning. Next. So we come to MDR. Now TB that is resistant to drugs is more difficult to treat, and we saw that. We saw a patient who was getting treatment twice and not responding. It could be MDR. So it is difficult to treat. But MDR, what it means is resistance to 2 of the most powerful first-line drugs. These are rifampicin and INH. So these are the 2 important drugs. And next we have something which is worse, that is XDR, which is extensive drug resistance. That is MDR, that means rifampicin INH is resistant. Plus, there is resistance to fluoroquinolones. These are the 2 most important, is the most important drug to treat, MDR TB because it's a part of the regimen. And at that time, it was second-line injectables. We saw that the patient got quinolones, that was levofloxacin, along with kanamycin. These were 2 important drugs. But if they are resistant to 3 drugs, in that case, it was called XDR. Now there's a slight change of definition. We have a new classification of drugs because injectables are no more used. And when we come to the drugs, we'll talk about what does XDR mean. So resistance can result from either transmission from one person to another of resistant strain. It could be that patient has already got a resistant infection from another MDR patient. So they are having a resistant strain, or failure of previous treatment. Maybe the patient has not taken treatment, as we have discussed earlier, the various causes. And we find that this is gradually increasing. Next. When we talk about the burden of DRTB, drug-resistant TB, MDR will talk specifically in India. 27% of the world's population of MDR in India, of 5 lakh nearly patients worldwide, about 1.25 are in our country. So that there is a burden. The number is very high. Next. So when we are dealing with drug-resistant TB, we know we treat drug-sensitive TB with 6 months, but here the treatment till now is up to 20 months. So it's a long duration of treatment, and they are dealing with toxic drugs. They're comparatively less potent. They are, because of long duration, we lose the patients since you're dealing with toxic drugs. They're high default rates, a lot of LFUs, and there is poor success rate of patients who are put on treatment. Like I said, the treatment with drug sensitive, we should be able to cure nearly 90 to 95% of our cases. Next. So surveys have been done. I just want to tell you how much is the problem of MDR amongst the patients we are treating. On the right, multiple surveys have been done. The last survey which was done in India, pan-India, was in 2014 and 16. This is the most recent survey. And amongst the new patients, these are patients who have never taken treatment. We'll have about 2.84% patients who are, MDR from the very beginning. So the patient we saw here could be amongst one of those about 3% of people who could be MDR from the very beginning, in spite of the fact they have not taken treatment. And amongst the previously treated, that means the patient who has taken treatment earlier, this number goes up significantly. It's about 11.6%. So the number depends on whether the patient, when you're dealing with a patient who's taken treatment earlier, we have to ensure the drug resistance is not there, because the the percentage is quite high. Next. Now, we are talking about, last you see is the i-NITH resistance. i-NITH is an important drug of the regimen. If we have resistance to this drug alone and sensitive to the rest, we find the outcomes are poorer than when you deal with drug sensitive TB. From 90% to 95%, this can come down to about 80%. And when we treat with a drug sensitive regimen. So i-NITH resistance is pretty high. Amongst the new cases, it is 11%. And in the previously treated, about 25% of the patients are having i-NITH resistance. So they have to give a regimen which is specifically made for this. We cannot give a drug sensitive regimen for these patients. Next. And this is just to tell you, because this is the mode of treatment which was followed in this patient. We started the PMDT treatment in 2006, and the patient which was put on treatment was put on the regimen, which was basically the regimen of a standardized treatment regimen for MDR, the third one, 2012, where a patient received 6 months of kanamycin, levo, cyclosporine. You saw that regimen, and it was a 24-month regimen. And then this patient was followed up after finishing the regimen with the XDR regimen, which was 30-month regimen. And it was a much stronger regimen with capreomycin, PAS, high dose, and very toxic regimen, you can see. So wondering whether this patient needed to be given this regimen because the patient had already completed treatment for drug resistant MDR regimen, that's the one above that. And the patient has did not show presence of a live passive line. Next. So these were the conventional regimens. And what were the results? What we see in India, the success rate since 2006-7, when we started this regimen, till recently we are using, till 16, till we have availability of newer drugs, which we'll discuss now. The treatment success of MDR is roughly half. 50% of all these patients get cured. And when we're dealing with XDR, on the right side, we only have 1/3 of the patients, that is nearly 30% only, are successfully treated. So the success rate is very poor. This just shows that if the patient is having, treatment, make sure you treat it properly, and there is no, development of drug resistance, because the results get poorer and poorer with treatment. So this was old. Even the newer results, when we are using newer drugs, is not as good as what we would expect it to be. Next. So these were the drugs what we talked about, which you used earlier. Now we have new drugs available. So this is a new classification of a grouping of drugs for anti-TB drugs. So we have grouped them in 3. This is available since 2020. And this is the standard of care. And this is what we are following now. This is I'm discussing because this will tell us how you need to treat TB now. So we have group A drugs, group B and group C. And these drugs are, from up below are the ones based on how efficacious they are and how safe they are. Depending on the efficacy and safety, they have been grouped as group A, B, and C. Group A are the quinolones, that is levo and moxifloxacin. Group B is a new drug called bedaquiline. Group C is a drug called linezolid. Group B, you have 2 drugs, which are clofazimine and cycloserine. So group A has 3 drugs. Group B has got 2 drugs, clofazimine and cycloserine. And group C has multiple drugs. And we add these drugs only if we cannot use the group A and B drugs. So when we make a regimen for MDR TB, that means the patient is rifampicin i-NITH resistance. So these drugs have to be chosen from the group. And group C, we have ethambutol, delamanid, pyrazinamide. You can see the list. And for India, we are not used, and we use these drugs, substitute from up and below, depending on if we cannot make a regimen using the first 2 groups. So when we make a regimen, we include all the 3 medicines in the group A, and in group B. Here we have written 1, but for the Indian guidelines, we are using both. So this is WHO guideline. These are the WHO grouping, but for Indian, we are using both all the 3 group A drugs and both the group B drugs. However, if the patient cannot take any of the drugs in either of these groups for whatever reason, maybe the patient is moxifloxacin, levoflox resistance, since we cannot use it, we'll have to group to group C to make a group of 5 drugs. Or if a patient cannot take, cycloserine because of, any reason, because of seizures, in that case, we move again to group C. So group C, the sequence is not what we show here. For Indian, we have the first drug we replace is delaminate, which is a new drug. And this is followed by amikacin injectable. What we have seen is earlier, all the regimens were injection based, and now all our, regimens, we try to make them as injection free. The third drug in the replacement will be paracetamide, and the fourth will be ethironamide, and we go down gradually. Imipenem, PAS, and ethambutol are lower down on the list. What you find here is the drugs which we were using earlier, especially kanamycin and capreomycin, are no more used as antitubercular drugs, because the data what has come out and published few years back show they were associated with poorer outcomes, and they are no longer recommended in treatment of MDR. So these are the groups of drugs which we use. Next. So what we have are we have 4 types of TB now. A drug-sensitive TB, we know it's a 6-month treatment. That means the patient is sensitive to both rifampicin and INH. Then we have DRTB regimens. These are the 3 which can be INH resistance with sensitivity to the rest of the drugs. Most of the drugs, especially rifampicin, it is called H-mono or poly-DRTB regimen. We have a separate regimen for this. Then we have a shorter regimen, which is only for MDR patients, not more than that. A patient is XDR, we cannot use this drug. And the next one is oral longer regimen, which is for MDR as well as XDR. And these are for people who cannot be given shorter regimen. Everybody can't be given shorter regimen. So anybody who can't be given shorter regimen will be given a longer regimen. So for treatment of drug resistance, if the INH resistance is only there, we treat with H resistance regimen. If the patient is MDR, just a plain MDR, not anything more, just rifampicin INH resistant, we give a shorter regimen. The duration is 9 to 11 months. And then if we cannot give a shorter regimen in a patient of MDR or a patient is XDR, we have a longer regimen where the duration is 18 to 20 months. So these are the 3 main regimens. So we talk about, very short, I'll talk about what is a regimen for MH monopoly. That means the patient is sensitive, resistance to INH, but sensitive to rifampicin. You saw that when our regimen we give for drug sensitive, we have 4 drugs, rifampicin, INH, ethambutol, paracetamide. Since INH resistance, we use levofloxacin here, which is used here as a replacement. And the duration is for 6 months of treatment. We extend this treatment to 9 months in patients who have a severe form of disease or who convert late. And I think we'll end here. This is the most important regimen. We'll not talk more than that. So this is a regimen. Just want to sensitize you that there is a regimen if patient is INH resistant. We do not use the same regimen as for drug sensitivity. Next. Then we have a shorter regimen. Like I said, the duration of this treatment is 9 to 11 months. And this regimen is only given if the patient is MDR. Everybody is not eligible for this regimen. And the regimen has 2 phases, which is 4 to 6 months of intensive phase where you use 7 drugs, these which are all shown here. And after that, when the patient has converted for next 5 months, after 4 months, if the patient doesn't convert, we give it for 5 months, this intensive phase. If it doesn't convert, we give it 6 months. If it still doesn't convert, we call it failure. Then we move to longer regimen. But after 6 months, we give a continuation phase, provided the patient is negative, and we remove some important drugs which are toxic. These are not important drugs, they're toxic drugs, especially ethironamide, high-dose INH, and bedaquiline will be not part of the regimen. So the patient will continue getting levofloxacin, clofazimine, Z, and E in this regimen. So this is 9 to 11 months. And the results what we have got in India is that we are getting about with, earlier we were using injections in place of bedaquiline. Now we have moved towards all oral shorter regimen. The earlier we were getting about 60-65%. success rate with this regimen with injectable. Now with bedaquiline, studies worldwide have shown that there is 10% to 15% improvement in the outcome. We expect to have 75%, success, provided the patient, selection is proper, and only those eligible for this regimen are given. Next. So who are the people who get this regimen? Everybody cannot get this regimen. I said this is a shorter regimen. It's better regimen. It's a good regimen. So eligibility come next slide. Next is patient who is rifampicin resistance, who's an MDR patient, but he should be sensitive to fluoroquinolones, because in this regimen you saw that besides bedaquiline, we are not testing for bedaquiline. The patient has been put on fluoroquinolone. He has been put on clofazimine, and he has been put on ethonomide. These are all second-line drugs. We make sure that this patient has not taken these drugs earlier. Next. So other inclusion criteria is that no history of exposure to previous treatment with these second-line drugs. That is bedaquiline, levoflox, ethonomide, or clofazimine. If a patient has taken them more than 1 month, or unless we show that the patient is, drug sensitivity shows they're sensitive, we cannot use this regimen. We can only use go to longer regimen. Extensive diseases there, the bilateral cavity, there's a bilateral disease, a severe form of disease, extrapulmonary, like miliary tuberculosis, you have CNS TB, you have abdominal TB, which is bad. In those cases, we don't use this regimen. So you have a lot of people who will not be eligible for this regimen, including lactating ladies or a pregnant female. Children aged 5 years or to less than 18 years of age must have, 15 kg, at least weight before we can use bedaquiline in these patients. So a large number of people will not be eligible for this shorter regimen based on these criteria. Next. The longer regimen, like I told you, is 18 to 20 months, where all the 3 group A drugs and 2 group B drugs are given. Unless they cannot be given, we replace it. Duration is 18 to 20 months, and bedaquiline is only given for the first 6 months. Very rarely we need to extend it further, and these are special cases. And for XDR, that means the patient, I'll just say a word what XDR means. XDR is a patient whose MDR, that is resistance to rifampicin INH, along with fluoroquinolone or any of the 2 group A other drugs. You have other 2 group A drugs, that is linezolid and bedaquiline. If we know the patient is resistant to them, we call that XDR. Next. So this is the standard of care. For XDR, we give 20 months. Next. Next. So the present standard of care is shorter oral bedaquiline containing regimen. Earlier we were using injectable. Bedaquiline is used now in place of kanamycin because of the toxicity. We are not using kanamycin alone, and we've already discussed this regimen, which is about 9 to 11 months, and the longer regimen, which is 18 to 20 months, where they are using 5 drugs, where we have a newer drug bedaquiline used, which is for 6 months, and linezolid, after 6 months we decrease it to from 600 milligram to 300 milligram because of its toxicity. Next. What next we are looking at? We need to shorten the duration. Even 6 months, we have 20 months of regimen, then we have 9 to 11 months when most of the people, a lot of people will not be getting that regimen because of exclusion factors. So we must have a regimen which is shorter. At the moment, the longer regimen is 18 to 20 months. So we must have simplified 4 drugs at the most, and we must have a good effective cure rate, more than 90%, like we have in drug sensitive TB, and minimum toxicity. Otherwise, the patient will not take the drugs, and we should be able to give these drugs in the periphery rather than having the patient to come to a higher center. Next. So based on this, a study has been done, which is an old study now, because which was published in 2020, where they treated XDR TB. Now, this is a very severe form of TB. The patient is resistant to rifampicin, INH, quinolones, along with injectables at that time, and the patient was put on 3 drugs. These are 3 drugs: bedaquiline, pretonamide, and linezolid. These are 3 drugs which were used, and pretonamide was recently, approved that time, and this duration is 6 months. And this was used in XDR as well as MDR people, and most of the patients were XDR, and they're used even amongst the HIV patients. What they found was an excellent results. They in 6 months of therapy. This is a 6-month regimen, and they got 89% cure rate in XDR and MDR. The cure rate was 92%. Roughly 90% of the patient has a successful outcome after 6 months of treatment. However, linezolid, it has been used in the dose of 1200 milligram. We had a lot of toxicity. Peripheral neuropathy at times, which can be severe, was seen in 81%, and blood, bone marrow suppression was seen in nearly half of the patient. So in a dose of 1200 milligram, even the outcome was excellent. And now we have followed up these patients, and these are relapse-free, minimal relapses are there. We had a 90% success. Either drugs which are for 6 months, just 3 drugs, and then in a patients who were very high form of TB, very resistant to most of the drugs under the program. Next. Now, just to take care that whether we can decrease the toxicity of the drugs, provided by linezolid, a Xenix trial was done, and this was done multiple sites, and they decreased the dose of drug linezolid, which was causing most of toxicities. Like 80% had problem with their neuropathy, and half of them had bone marrow depression. So these were issues. So Xenix trials next. Xenix trial showed that the BPAL regimen, the same regimen, remains effective against highly drug resistant. There's something coming in between. Okay. Highly drug resistant strains of tuberculosis with reduced dosage or duration of linezolid component of the regimen. So decrease at the duration as well as dose, and they found that the results were as good, and the toxicities which were seen in nearly 80% came down to nearly a quarter. Only 1/4 of the people had some problem, and they were easily manageable. So this became a standard. Next. So based on these results, if we move to the next one. Based on this, in India, we needed to study whether this regimen, which was used in South Africa and other countries with low dose of linezolid, can be effective. And this study, what was called a modified BPAL, that is bedaquiline, ketonamide, and linezolid, would it be effective? So these are the sites the study is going on, and I'll share the results with you. Partial results next. So what we did here was, in India, we used the same dose of bedaquiline, ketonamide, linezolid 600 milligram, that is half the dose what was used in the next trial. And another thing we tried was whether the linezolid high dose, that 600 milligram been given, followed by half the dose. So for 2 months and 3 months, linezolid was given in the 2 different arms, was at 600 milligram, and for the rest 4 months, it was decreased to 300 milligram. And the results have been very encouraging, and soon this could be our treatment modality for patients of MDR and XDR in India. Next, based on this is everybody is not eligible. Some people who are eligible, like people who have taken these drugs earlier, will not be eligible. People who are less than 14 years, they will not be eligible. Pregnancy patients with pregnancy will not be eligible. But there are patients eligibility, and patients who are ineligible. There are guidelines. But this is what we are looking at in very near future as a mode of treatment in our country. Next. So we have seen 2022, we were using, till now we are using 20 months treatment for MDR, longer regimen, and 9 months of treatment with a shorter regimen. What we are looking now is in the 23 to 25, a regimen with BPAL and BPAL, and we can use a moxifloxacin. These are 2 trials, 2 regimens which we are planning to launch soon, and this will be the standard of care. And what we are looking forward is in 2026, a regimen further decreased to 3 to 4 months. So what we have seen over the time, when we were treating treatment, when we started, the patient that we discussed took treatment for 24 months, then for XDR, it took for 30 months. And now we are using 20 months and 9 months, and we're looking at 6 months very, very soon. And soon and ahead, let's hope we have a regimen which is a much shorter duration, because the shorter the duration, the less toxic duration, the success rate goes up, and adherence and acceptance goes high. Next. So thank you so much for patiently listening, and I'm ready to take any questions you have. Thank you so much.
Thank you, sir. Thank you very much for this complete. It was a totally complete talk in MDR, like on drug-resistant TB. And the case was already discussed and recommendations given even before we started the talk. I would say that after everything that Dr. Ashwani has explained so clearly, I would only like to highlight just 1 or 2 points that if you want to take home something very important from this talk, remember that there is a drug-sensitive TB, which is sensitive to all first-line drugs. Then there can be a mono TB, so then there is a drug-resistant TB, which can be mono INH, which can be MDR, and which can be XDR with sort of pre-XDR in between. So these are the definitions, and the type of treatments are CAT1 for drug-sensitive treatment, which is for 6 months with the possibility of extension to 9 months. If we have H resistance only, and the patient is sensitive to R, Z, and E, then we replace INH with levofloxacin, and this is called mono H resistant TB, and this is for a duration of 6 months, extendable to 9 months. After that, for a patient of MDR TB is somebody who is resistant to both R and H out of the first-line regimen drugs, and not resistant to other drugs or unknown resistance to other drugs. For such cases, we use a shorter oral DRTB therapy regimen. And for patients who do not do well on this regimen, who fail this regimen, or who have XDR TB, we do the longer all-oral DRTB regimen. So it is 6 months. Mono resistance is 6 to 9 months. Then shorter duration, shorter one is 9 to 11 months, the shorter MDR TB treatment. And the longer all-oral MDR TB treatment is for 18 to 20 months. The reason I'm only telling you this much in brief is because we know the minute we see a resistance, we send them to the district TB officer or to the nearest DRTB center from the ART center. And a lot has been talked today, and I hope you were able to understand that. So, sir, any last comments from you?
No, I think the take-home message you have already covered, because this was just a sensitization, because you cannot do everything. They'll be sending patients still, but they should be aware what are the different type of TBs, what you have explained, and how long is the duration. And the take-home message is ensure patient is adhering to the therapy so that they do not develop drug resistance and make it difficult to treat.
Okay, thank you, sir. So irregular treatment is a big culprit by which a patient can develop DRTB. And we have to understand that there are different tests for testing for TB, like smear, like molecular tests, which are CBNAT and LPA, and the culture. But the only test which can tell you whether the bacteria is live or not is a culture. The rest of the 2 modalities can pick up even dead bacilli. So at least a molecular test is not a good idea when we want to do it in follow-up. Once you have a resistance, once you have a bacilli and a pattern of resistance in CBNAT during an episode of TB, it could also be replicated during the other episodes of TB with the so-called TB, but actually it is a leftover dead bacilli from the previous episode. So these are a few take-home messages, and have we launched the feedback? So the feedback is in the chat box. Everything else went to your email or registered phone number, but the feedback is in your chat box. I now request you to do the feedback, and once the feedback is done, I now hand over the mic to Dr. Jyoti Sharma to discuss the results of the post-test.
So now I'll tell about the right answers of the questions. So the first question was, what are the most important causes of MDR? The irregular therapy and improper dosage and duration. So the correct answer for this question is irregular therapy. Another question was, what test is done to ensure that the bacilli are not dead? The options were smear microscopy, molecular testing, culture of bacilli. So the correct answer for this question is culture of bacilli.
So with this, I would like to thank Dr. Ashwani, and I'd like to thank all our ART centers who joined us today for this session. And I thank Dr. Jyoti, Dr. Rajesh, and Jyoti, Mr. Rakesh, and Mr. Nitin, who are here at the back end and help us to make this session possible. Thank you very much.
Thank you.
Thank you.